Understanding Hypernatremia, the types, causes, and management. Explained. Hey everyone, welcome back to the channel. Today, we're diving into a topic that doesn't always get the spotlight it deserves. Hypernatremia. Sounds technical? Don't worry, we'll break it down together. So, grab your coffee, get comfortable, and let's get started. What is hypernatremia? Alright, first things first. What exactly is hypernatremia? In simple terms, it means your blood sodium level is higher than 145 milliequivalents L. It usually happens because your body doesn't have enough water compared to sodium, and that can be due to not drinking enough, losing too much water, or other medical issues. Think of it like your body's water-sodium ratio getting thrown off balance. The three types of hypernatremia now. Let's break hypernatremia down into three main types, each with its own story. 1. Hypovolemic hypernatremia. More water lost than sodium. So, picture this. Your body is losing water faster than it's losing sodium. This happens with things like taking certain diuretics, those water pills your doctor might prescribe, osmotic diuresis, from conditions like high blood sugar or using mannitol, severe diarrhea, vomiting, burns, or even heavy sweating. When you lose all those fluids, you're left with more sodium in your blood. How do we manage this? If you're really dehydrated or unstable, doctors start with isotonic saline to stabilize you. Once you're steady, they switch to fluids that are less salty, like half-normal saline or just plain water. And of course, they tackle the root cause, maybe stopping those diuretics or treating the diarrhea too. Euvolemic hypernatremia, pure water loss. Next up, euvolemic hypernatremia. Here, you're losing just water, not sodium. The main culprits? Conditions called diabetes insipidus. Either central, your brain doesn't make enough ADH, or nephrogenic, your kidneys don't listen to ADH. Or sometimes, folks just aren't drinking enough water, especially elderly people or those with impaired thirst. How do you fix it? If it's central diabetes insipidus, the go-to is a medicine called desmopressin and making sure you're drinking enough water. For nephrogenic, the approach is a bit different. Sometimes doctors use thiazide diuretics. Counterintuitive, but it works. A low-sodium diet, and NSAIDs, plus stopping any problem drugs like lithium. Water replacement, either by mouth or IV, is key. 3. Hypervolemic hypernatremia, too much sodium intake. And finally, we have the rarest type, hypervolemic hypernatremia. Here, you actually have too much sodium in your body. This can happen if you get too much hypertonic saline in the hospital, or if there's a mineralocorticoid hormone imbalance, like in Cushing's syndrome or certain adrenal conditions. Treatment? Diuretics like furosemide to help get rid of the extra sodium, plus fluids like D5W to restore that delicate balance. If there's kidney failure, dialysis might be needed. General principles. How do we treat hypernatremia safely? Alright, here's where things get really important. We have to be careful about how quickly we lower sodium levels. If it's acute, less than 48 hours, we can correct it faster, 1 to 2 milliequivalents per liter per hour. If it's chronic, over 48 hours, go slow, about 0.5 milliequivalents per liter per hour and no more than 8-10 milliequivalents per day. Going too fast can actually cause swelling in the brain, which is super dangerous. What fluids do we use? Usually, hypotonic fluids like D5W or half-normal saline. If someone is super dehydrated and unstable, we start with normal saline first to stabilize. And you've got to monitor closely. Doctors will check sodium every couple of hours at first. Keep an eye on urine output, and sometimes check urine osmolality to help figure out which type of diabetes insipidus you might have. Key takeaways. Diabetes insipidus has two types. Central, responds to DDAVP, and nephrogenic, doesn't respond. Never lower sodium too quickly. Slow and steady wins the race here. Thirst is your body's best defense. So people with impaired thirst, like the elderly or those with dementia, are at higher risk. That's a wrap on hypernatremia. If you found this helpful, don't forget to like, subscribe, and hit the bell for more easy-to-understand surgical podcasts. Drop your questions or experiences in the comments below. We love hearing from you. Thanks for tuning into the Everything Surgery podcast. Dissect the extraordinary.